Hi, and welcome to Fairview Range Focus. I'm David Hall, Chief Administrative Officer for Fairview Range here in Hibbing. And during this monthly program, we talk about health issues that affect you and the community. And today, we're going to talk about anesthesiology and anesthesia. And I am joined by Dr. Phil Mickelsen. Thanks for joining me, Dr. Mickelsen.
My pleasure.
And we're going to talk a little bit about anesthesia and anesthesiology. And so maybe a good place to start, if you would, because I know you're relatively new to the community. You could tell us, just introduce yourself and tell us who you are and background and so forth.
Absolutely. We just moved here last September, my wife and I, and we hail from New Mexico. Oh. And so it's quite a change for us.
I bet.
And we've enjoyed moving here. It's been a real pleasure.
Good.
So I did my undergraduate degree in New Mexico, and that's kind of how I became acquainted with New Mexico, although I'm originally from Colorado.
Okay.
And so that's...
so you've seen snow before?
I have, yes. And then that's where I actually went to medical school, was Colorado.
Okay.
And then I did my anesthesia training or residency at Dartmouth in New Hampshire.
Okay. So again, places get a little bit of snow
yes,
as well.
Yes, always seemed to have a little snow. And even in New Mexico, believe it or not, we were what we call high desert. And so actually had about 7,000 feet altitude, so we did get snow there as well, ironically.
Yeah,
so.
Good. All right. So maybe you could describe a little bit, for a lot of people may not realize the length and breadth of which it needs to go through to become an anesthesiologist. Could you speak to that?
Sure. It's actually very similar to other physicians. Basically, we all go to the identical medical schools, and following medical school, we then have to go on to anesthesia training or anesthesia residency. So just as a family practice doc or an internal medicine doctor or a pediatrician would have to go to a pediatric residency, we do the same thing. Ours is just an anesthesia specialty.
Mm-hmm.
And so basically, once you have your undergraduate degree, you would attend medical school for 4 years, and following that, then you do another 4 years to become an anesthesiologist.
Okay. 8 years.
8 additional years after college, yes.
Yeah.
Mm-hmm.
After college?
After
your
college.
undergraduate?
Correct,
right.
yeah.
Okay,
so
good.
I went, so basically, technically 13 more years of school after high school.
Yeah, very long time.
Yeah.
Okay.
It can, I guess it is, yeah.
Yes, I guess it is. It definitely is. How about, now you're the medical director for the Anesthesia Department.
Correct.
Could you describe a little bit about your Anesthesia Department and what that consists of?
Absolutely. So our Anesthesia Department consists of myself as the medical director and the anesthesiologist on staff, and then I have 7 certified nurse anesthetists, well-qualified, very skilled advanced practitioner nurses that have specialized in additional training past their nursing background to provide anesthesia services. And so our department is basically the 8 of us at this point, eventually maybe expanding.
Okay. Okay. So, and I know that for some people that's been confusing to them. A lot of times there's more CRNAs than there are anesthesiologists, yourself.
Yes.
That there's a significant difference between those two.
Yes. Again, the nurse anesthetists are well qualified, and what they are is they are basically nurses that have their 4-year nursing degree that have gone on to do additional advanced practitioner anesthesia training.
Okay.
And so they do 2 years of additional schooling to be skilled in anesthesia. The difference, again, is just experience and usually obviously a physician's approach versus a nursing approach. But again, their skill set is strong in anesthesia. And my job as the anesthesiologist is to sponsor them and to ensure that everybody is following the standards of care and providing the best practice and safest procedures that we can.
Okay. So is it accurate to say that you provide supervision from a clinical standpoint?
From a clinical, absolutely.
Practice?
That's probably the best way to word that.
Okay. All right. Very good. And the patients that are coming through for a surgical procedure, would you typically see each patient, or sometimes?
Yes,
every patient?
depends on, usually what happens is, the way this works is once a patient is brought into the operating waiting area, what we call the preoperative area,
Okay.
I would actually visit with the patient and after reviewing their records, make sure that they're set and ready to go for anesthesia. Then the nurse anesthetist, or the CRNA, as they're called, would actually be the one who will be with them the entire case. I'm usually there in the beginning of the case and at key points, key interval points, including at the end.
Okay.
And so we kind of work as a team for each case.
Okay. So could you describe maybe somebody who is contemplating or going to be having surgery, what's a typical process they might go through in preparation for that?
Sure. Typically, they would have to be seen a lot of times by their primary care physician to be what we call medically cleared, meaning that they are stable enough to undergo the rigors of surgery, you know, the stressful response of surgery. We basically require that patients meet a standard of care in providing the safest level of anesthesia for them. And that entails sometimes just lab work, sometimes it involves x-rays, sometimes it involves seeing a specialist, depending on what types of health problems those patients have.
Okay.
And just making sure they're what we call optimized for anesthesia and for the procedure.
Okay.
And once that's done, then usually a surgery date is scheduled. They would be, again, once they arrive, a nurse will take them to a preoperative area, and that's where I will meet them and interview them personally and discuss the aspects of anesthesia and discuss the plan of anesthesia. And usually as soon as the operating room is ready, we all head back, provide anesthesia, and then once the surgery is done, we are actually the ones that will transport them to a recovery area. Sometimes it's the same preoperative area, but sometimes it's also different depending on the nature of the surgery. And there we help the patient wake up and make sure they're stable and safe.
So when you're talking to a patient, like preoperatively, is there any particular things that you're really trying to focus in on or trying to listen for at all when you're talking with a patient?
Well, obviously I want to make sure the patients are as comfortable as possible. Sometimes that's not always easy, you know, given that patients are nervous or they might be a little scared of what's about to happen. I'm also looking at their history and trying to find specifics as to, you know, oftentimes how are they doing from a functioning standpoint, meaning are they having troubles with their hearts? Have they had recent troubles with their hearts? How, you know, have they seen people in the past that, you know, physicians that specialize in heart care, and, you know, what do they recommend? And so those are the kind of things I'm trying to elicit in response. And I'm also trying to make sure that they're not, you know, that they have questions that we can answer and really establish a relationship of trust between us and try to emphasize that, you know, our goals are the same as theirs, and that's to get them home safe and sound.
Right. Okay. Interesting. So we often hear people talking about local anesthesia versus general anesthesia. Could you describe that for us?
Absolutely. There's actually several different degrees of anesthesia that we can provide. The most extreme you often hear of is what's called general anesthesia. General anesthesia simply means that you are all the way asleep. Okay. It means that you are rendered unaware of anything. And oftentimes general anesthesia does entail the assistance of a breathing mask or a breathing tube, depending on the nature of the surgery, all the way up to what we call conscious sedation, which is a different extreme or end of the modality, where we are providing light sedation with what we call local anesthetic, as you referred to earlier, which basically means that we're numbing up the area of interest. And that can often be done for cases where you're having a skin lesion removed and you don't need a whole lot of sedation. And so we try to tailor the anesthesia specifically for the needs of the patient and the nature of the surgery itself.
Okay.
In between those are different degrees of sedation, as you can imagine. If you're coming in for a colonoscopy, say, we often do what's called deep sedation. So obviously not many people want to be awake for that, and so we provide enough anesthesia that the patient is literally snoring through the procedure, unaware of what's occurring. but breathing on their own, so they don't need the assistance of a breathing mask or breathing tube.
Right.
We also do what's called regional anesthesia.
Okay.
Regional anesthesia is typically something people have often heard of if they've had a knee replaced or a hip replacement or hip surgery, or oftentimes extremity type surgery. We can actually numb up the limb that's being operated on. And we can still provide some sedation and things like that, but that way when I say numb, we actually are numbing those areas so that the patient really doesn't feel pain or discomfort. Mm-hmm. And so those are always possibilities that we can provide depending on the nature of the surgery.
Okay.
So really we just tailor what the patient needs in relation to the operation that they're having.
So it's probably, is it safe to say there's probably no particular patient anesthesia that's exactly the same as the last one? I mean,
no, and that's the main thing is you know, two patients can come in, they may be having the exact same surgery, and typically patient preference, of course, is always first and foremost. One person may say, oh, I would definitely like to be all the way asleep for this. Another person may say, I would prefer to have regional anesthesia. Mm-hmm. And we also have to consider if it's appropriate, obviously, and also we have to consider the nature of the patient's health to begin with. Is it safe to do that level of anesthesia for that person?
Right.
So absolutely, it's tailored individually to each patient.
Okay, good. I like that.
Yeah.
I'm sure the patients do too. What about childbirth? I know that anesthesia plays an important role in childbirth.
We
Maybe
do.
Speak to that.
Well, obviously, you know, we provide, first and foremost, anesthesia provides as much as we can a service to try to eliminate pain. Pain is always a very important concern in surgeries and in childbirth, and specifically we have the ability to help women during childbirth by providing what we call epidurals, or another term often is the spinal or intrathecal, okay, that basically can provide supplemental pain relief. This is often done through a little tiny access to their back. We basically put in a small little tube or a small needle basically to deposit some medications, and those medications kind of numb the nerves that are responsible for pain.
I see.
And we can do that because it still allows the woman to be awake and oftentimes very comfortable to the point where they can take a nap. Okay. And so it is often something that the women can have in exchange for the pain.
Okay, very good. And after surgery has occurred, and then you've touched on it, the post-anesthesia care, or I think what used to be called recovery room.
Correct.
What's the role of anesthesia or anesthesiologist in the recovery room?
So particularly my role is to make sure that when a patient comes to the recovery room that they are going to be able to leave the recovery room at some point. That's our goal. Mm-hmm. And so what we want to do is make sure that the patient stays as stable as possible, that they're comfortable. And typically that focuses on really three aspects. One, temperature. It may seem fine, you know, it's always a little cold in the hospital, but temperature can be a very important thing to patients who are cold and shivering. Yep. So we really try to manage their comfort level with temperature. The second would be pain control, obviously. Okay. We want to make sure that as much as we can, that the patient has their pain under control to either a satisfactory point as much as we can, or that we can provide additional medications to alleviate that. And really the third point is that we try to control nausea. Unfortunately, nausea is a very typical side effect of anesthesia, and one that patients are very concerned with. And so we really try to optimize them by giving them preventative medications oftentimes, as well as medications after the fact to try to help control that nausea situation. So in a nutshell, we want to make sure that they're as stable as possible and in preparation for being able to either be discharged to home or be discharged to upstairs on the floor.
The floors, okay, good. You talked about the visiting with patients, and then we talked about going to recovery room. I'm thinking, as number of years you've been doing anesthesia, do you find that there's a common questions that or concerns that patients have prior to anesthesia that
Absolutely. Well, most patients obviously want to know what kind of anesthesia they're going to be having.
Okay.
That's always a big concern. They also are very concerned, as I kind of already alluded to, with their comfort level after the operation. How are they going to be feeling? Are they going to be sick to their stomach? Are they at increased risk for that? How about their pain control? What is their plan for pain management? And the latter part, you know, is like I said, very, very important for them because pain, no one enjoys pain. And so we really need to focus on trying to make sure that they're as safe and stable as possible while providing the proper level of anesthesia and pain relief.
In your career, number of years that you've been in providing services in anesthesia, have you seen lots of changes that have occurred in anesthesia, or is it a profession that is evolving constantly?
It is a profession that's evolving constantly. You often hear back in the day, prior to mine, I've been doing this for, I've been in solo practice for about 11 years, but I've been doing anesthesia now with residency about 15 years. You often hear of stories of this evolution that has occurred, and even today new medications are coming out all the time that allow us to provide longer acting pain relief with fewer side effects. We are getting better and better with technology and safety, and that's really where anesthesia is going, is to provide the safest level of care we can. Statistically, they say it's about 400 times safer to have anesthesia than it is to drive to the hospital to have anesthesia.
Really?
It's that level of safe at this point. So it's really swung in a direction of patient safety and patient comfort.
Okay, so that I heard you mention technology. So technology is all around us, and certainly in the healthcare, it seems like it's so predominant. That plays a big role as well within anesthesia.
It does.
Okay.
We constantly have monitors that will be attached to the patient during the procedures, actually before, during, and after the patient. And what these monitors do is they basically relay to us the body's what we call vital signs. So blood pressure, heart rate, temperature, respiratory rate, oxygen level, all these kind of things. And this provides constant information for us to interpret as care providers and be able to adjust settings that will allow us to continue to provide anesthesia, or in the case of recovery, be able to provide medications to try to alter and adjust, and focus our level of care even better, and primarily to provide the safest level of care that we can for the patient.
Okay. What about, we talk about inpatient surgery and outpatient surgery, and certainly in my career I've certainly seen a big shift towards outpatient.
Yes.
Have you seen that to be the case?
Absolutely, absolutely. For a prime example of that is laparoscopic cholecystectomies, which are fancy terms for basically gallbladder removals. Almost all of those, probably in just not even 5-6 years ago, were inpatient surgeries, meaning that you stayed overnight or expected to stay at least one night over.
Okay.
And those are all outpatient surgeries typically now, and that evolution is occurring. More and more patients want to go home. They feel comfortable at home. That's where they would like to be. And again, we're trying to change and focus and really try to get patients as happy as they can with the experience. Surgery is not always the most ideal situation for everyone, and so we want to try to provide the best experience they can. And
Sure.
What better way than to be able to go home to your own bed?
Yeah. Well, along those lines, if I understand things correctly, you provide anesthesia services at the Northwood Surgery Center?
Yes.
Maybe you can describe a little bit
Sure.
about that, or
Yeah,
how that
so
works?
the Northwood Surgery Center has just recently opened in Virginia and is providing cases there. And we are actually our anesthesia department is also providing anesthesia coverage there. So when patients come there and they have what's called outpatient surgery, the idea being that there are surgeries that are optimized just for outpatient surgery centers like this one. Right. They will see us there, and we'll provide a complete level of care there as well. Again, everything from general anesthesia we've already discussed, to regional anesthesia, to local anesthetic with sedation.
Okay. So is there any particular types of surgery that you would say you know, you won't see as an outpatient? Is there types of, I know we're
Absolutely.
evolving, but...
Well, and those are typically any type of surgical procedure that's going to require the patient to stay overnight.
Okay.
Right now, things like hysterectomies or patients who are having heart surgery, oftentimes, or surgeries that we know there's going to be intensive monitoring that needs to be kept up with the patient after the operation. So typically those are the kind of surgeries you wouldn't see in a surgical center, for sure, because again the goal of the surgery center is to provide very fast access to their surgery and allow them to get in and literally get out as soon as possible.
Right, go home.
Yeah, and go home
Yeah,
and enjoy their day.
Yeah, okay, very good. Well, Dr. Mickelsen, thank you. I really appreciate learning
pleasure.
more about anesthesia, talking about the department, and what an anesthesiologist is. So I think you've helped a lot in helping us understand that better. So, but we're about out of time.
Okay.
So with that, I will again say thank you to Dr. Mickelsen, and thank you for joining us today and watching Fairview Range Focus. If you'd like to learn more about Fairview Range and the services that we offer, we encourage you to check our website, and also to watch for Fairview Range Focus next month for a new program. Thanks for watching, and have a great day.
Hibbing Public Access Television would like to thank U.S. Bank for providing us with studio space.